Okay, thank you.
Okay, thank you.
Yeah, I saw you press the button already.
Okay, good.
Okay, Justin.
Yes.
Um, it's gonna be the time
Okay.
for the talk, and we are very delighted to have the speaker for the onco team today, Miss Duscher and Miss Redmond, for introstomal. Sorry, long topic. One moment, please. Um, role of
Super.
wound and intrastomal nurse in GI cancer. Could Justin kindly introduce the speaker to all of us? Thank you.
Yes, I think I'll let Liana take the honor of that, but want to thank everyone for joining. Are we still waiting for Liana to join, or are you already there, Liana? Let's give her maybe just one more minute. Is that okay?
Okay.
Oh,
Hi, morning, Prof.
good morning, or
Hey, hi,
yes, or
Liana.
good afternoon. Hello, hi.
Good to see you. Nice to see you. Welcome to the call.
Yeah, no, absolutely. Nice to see you all. I can see some of you, but I'm excited for today's talk. I think Sarah has joined us. Um, Very briefly, as it is 5:01, I'll wait for some more people. There's Sarah. Hi, Sarah. Thank you
Hi,
for being here.
absolutely.
I I have to say, as a colorectal surgeon, I cannot do my job without an educated and really highly trained enterostoma team. Um, you cannot be a colorectal surgeon without, having to do at a point an ileostomy or a colostomy. We know very well what it means for the quality of life of those patients. And although I've been trained on where to mark a stoma or, the difficulties of bringing up a stoma, the technical difficulties of making a stoma at times, the value of a team that can take care of those patients, that they're the most up to date in the appliances, in the technology, in receiving the calls, in preparing the patients, is, I don't know, it's priceless. Like I sound like the MasterCard ad, but it's truly priceless. And Sarah's team is amazing. That we are very blessed at OHSU to have four excellent trained enterostoma nurses, wound ostomy nurses, actually, we call them, but and that really help us out to take care of our patients. And it's an integral part of the team. And although we're not very close in proximity, we're very close in spirit and virtually and through our teams communicating with them almost daily about our patients. So I don't want to take more time from Sarah. I've seen her slides. I think you're all going to learn a lot and enjoy her talk. And there's going to be plenty of time for questions. So, Sarah, thank you and welcome.
Thank you so much. I appreciate that introduction. I'm blushing, I think. Yeah, I'm Sarah. I'm one of the wound and ostomy nurses here at OHSU. And I, first of all, thank you so much for the opportunity to speak with you guys today and to talk a little bit about what our role is here in the general GI cancer world. My colleague Emily was going to be joining me today, but she is currently this very minute giving birth to her first child. So it's very exciting here. But I know she'll be sad that she missed out on this opportunity. I figured the easiest way would be for me to share my screen to kind of go through some of the slides. Okay, I'm also very much a visual learner and have lots of props here, so I'll also be showing those throughout the presentation as well. So let me just share my screen.
And we have quite a number of the oncology nurse from various hospital cancer site to listen to you today. Thank you very much.
Oh, great. That is fantastic. Okay, so like I said, I'm Sarah, one of the ostomy nurses, but I wanted to, first of all, just let me introduce my team to all of you. So I'm so sorry, my PowerPoint wasn't working. Okay, so like Dr. Sickett has said, we're a team of 4 nurses. There's only ever 3 of us in the hospital at any given time. And actually right now, only 2 of us because Emily is on maternity leave. But all of us have different nursing backgrounds. We all came from different units before we joined the wound and ostomy team. I myself was a trauma ICU nurse for about 8 years before I came over. And so wounds were my specialty from trauma, but it was over the course of my education on wound and ostomy care that I realized that I love working with ostomy patients the most. It's my favorite part of the job. And I think my colleagues actually would agree it's their favorite part too. We love working with our ostomy patients. And speaking of my colleagues, there in the dark blue is Meredith. She comes to us from the oncology floors here at OHSU. So she had a lot of experience with GI cancer patients prior to this role. And then in the black shirt there is Emily, again, currently giving birth, but she came to us from the general surgery floor. So she also had a good foundational knowledge of ostomies before coming to this department. All of us were educated at Emory University. We all did the Emory distance program. And Emory over in Atlanta, Georgia, they have an incredible program and they prepared us for the certifying exam. So we all took and passed the certification exam. So now we're all certified wound ostomy continence nurses. And our goals as a department, we want to educate our patients in ostomy care and encourage independence and provide support after their discharge from the hospital. And that's just sort of based on how studies have shown that ostomy patients, they have higher quality of life scores when they've achieved autonomy in ostomy care and when they have a good support network after surgery. So we help our patients by providing information preoperatively. We provide education while they're in the hospital, and then we are part of their support network for the life of the stoma after they've been discharged from the hospital. And so that is what we are hoping to achieve with our patients. And so our experience with our ostomy patients, it typically begins with a member of one of our surgical teams reaching out to us and asking us to set up an appointment with a patient to discuss an ostomy and to site mark them. And so we call the patient, set up an appointment. Ideally, it's after the patient has already met with one of the surgeons so that they have a general idea of what the surgery is going to entail. We really depend on our surgical teams to let us know what the plan is and kind of an up-to-date idea of what the patient already knows, so that we are educating the patient for the specific kind of ostomy that we are thinking that they're going to get, versus kind of overwhelming them with all the information about, possible scenarios. So patient comes to our office, our little tiny office. Dr. Sikidis has seen it before. We call it our cloffice, our closet-sized office. But our patient comes and sees us there, and we will discuss the surgical plan, why an ostomy might be needed, talk about stomas and pouching, and then we site mark. And so the picture here is of the kit that we use. And, oh, pardon me, I lost my slide. Okay, but the kit that we use, and this kit is made by the American College of Surgeons, and I apologize here. And the kit in here, it has a booklet the patient can look through. It's better resource for after surgery. It's a home skills kit, so it's got information about the colostomy or ileostomy, tips and tricks for home. It's just a great resource for home. But what I specifically love about these kits is that they have little practice stomas. And so the patient can practice measuring a little styrofoam stoma, and then they can cut some sample pouches to the shape and size of that stoma, and they can practice ostomy care before surgery. And I'll talk a little bit more about that kit later, but that's all part of the appointment. So sorry, did my PowerPoint is it not being shared anymore?
Now it's shared.
It's now shared. Okay.
Yeah.
Perfect. So then let's just sort of talk a little bit more in depth about the pre-op discussion that we have. So the first part of the appointment, I generally will discuss just anatomy, very basic anatomy. So the patient has a better idea of kind of what we're discussing when we start talking about the ileum or the colon. So we have our little coloring book piece of paper here that shows the GI tract. And so something that I would say generally is when I'm talking with the patient, you eat your food, it goes into your stomach puts the food into the small intestine. Your small intestine's job is to absorb your nutrients. I like to think of it as the small intestine eats for you. After it's gone through the small intestine, it then goes into the large intestine, and your large intestine, I like to think of it as it drinks for you. It absorbs your fluids. So while it's traveling through the large intestine, the fluids are being absorbed, and by the time you pass it through your bottom, it is a formed bowel movement. So something very basic like that, so they have an idea of what we're looking at here. And so then I like to try to review the planned procedure, or what we at least know about it at that time. So for example, if we're talking about a low anterior resection and a diverting ileostomy, I like to tell them that, the general area of where a tumor, for example, is being removed, we're going to remove that area. Your surgeon's going to take that out, sew the intestine back together. And now we want to protect that suture line to keep you safe. And so in order to do that, we bring the small intestine up to the surface to make the ileostomy. And now your stool is diverted and your whole colon gets a chance to rest and heal. And going through that little talk right there, we have found has made a huge difference in our patients' attitudes as they are in our appointment, because a lot of times people are coming into their pre-op appointment feeling very overwhelmed and very scared. And many patients have told us that getting an ostomy was the part of the procedure that they were the most scared about. And so by explaining to them kind of the basic understanding of why the ostomy is needed and how it's going to be used to keep them safe, helps them to start accept the ostomy and become less scared of it. So we find that to be really important. And then we can start proceeding to talking about the stoma specifically. And so, I'm so sorry. I don't know how to move the slide along because it's wanting me to write something. Does anybody know what's happening?
Yeah, open it there, Sarah. Try if that helps at all.
It just wants me to highlight things and draw on it.
Is there a way to get out of that screen on the top left? Because is there a place to click off of the button, or can you close it and just reopen
Yeah, let's maybe stop
all
sharing for
presentation?
just a second.
Yeah, if
Start again.
you
Yep.
do that,
Yeah,
and
reshare
I'm
it
trying.
again. Yeah.
There we go.
Yeah.
We're back. All right. What would a presentation be
Thank you.
without some technical difficulties? Thank you so much.
Nice job.
Okay.
Well done.
So then we're going to proceed to talking about the stoma. And we like to show pictures in our office of what some healthy stomas look like. A lot of our patients have come into the appointment having done some online research, and they've been looking at pictures of stomas. And oftentimes they're looking at pictures of healed stomas. And so we find it's really important to let the patient know that a healthy stoma is red or pink, it's moist, but after surgery, it's going to be puffy. It's going to be swollen. It's going to be larger than what you're probably expecting, but don't be afraid. It's going to shrink. The swelling's going to go down. Oftentimes it takes 6 to 8 weeks for the swelling to go down after surgery. So the stoma that you see immediately after surgery while you're in the hospital is not necessarily the same stoma you're going to see after a couple of months. So we show pictures of an end stoma as well as a loop, just so they can kind of see what different stomas look like. We make sure to remind them that the stoma does not have the pain nerve endings. It's not going to feel pain. Patients are really afraid to touch their stomas after surgery because it looks like it would be very tender, and they're very intimidated by it. So we like to give them the heads up that you're going to be able to touch your stoma, clean your stoma. It's not going to hurt. We're going to be very gentle with the skin around the stoma after surgery because your abdomen's going to be really sore. And then we also kind of go into the fact that there's no longer a sphincter involved. So you don't have control over when the stool is going to be coming through the stoma. And so for that reason, you're going to be wearing a pouch. And actually that becomes a good transition into talking about the ostomy pouches. And so we show them what an ostomy pouch looks like. And we show them the kind that we stock here at OHSU, so they are familiar with the kind that will be on them after surgery, but let them know there are so many different styles of ostomy pouch, and we can find the one that works best for them, but this is the kind that we want them to be a bit familiar with. And so I show them this pouch to let them handle it, let them kind of play with it, ask questions. But we just talk a little bit about what routine ostomy care looks like. So emptying the pouch when it's 1/3 to 1/2 full, I'll show them how to empty the pouch from the bottom. This is like one of the lock and roll and lock pouches. And then we talk about how you change your pouch twice a week, every 3 to 4 days, and describe a little bit about how you use a special kind of adhesive remover to remove your pouch. You're going to just clean your skin with warm water, dry it really well, and put a new pouch on. And of course, multiple times in this part of the appointment, I'm letting them know we're going to go over all of this multiple times in the hospital. You don't need to remember any of this part. I just want you to be familiar with what the pouch is going to look like and know that it's manageable. We go over some of the features of the ostomy pouch, which is that the pouches are waterproof. The patient can shower, bathe, sit in a hot tub, go swimming with the ostomy pouch on. And then we can talk a little bit about there's a gas filter that releases the gas from the bag instead of the bag blowing up with air. And then again, you can see from the picture here, this is just a couple of the cabinets that we have in our office full of ostomy supplies. We have over 80 styles, I think, here in our office. And without overwhelming the patient, we just try to let them know we have so many options, and our job is to know what all of these options are for, what kind of patient that will work best for, and then to find the right one for the patient to get them into the right pouch. We want one that fits the stoma, fits the abdomen, and fits the patient's lifestyle. So at this point in the meeting, I usually like to kind of transition it over to the patient and ask them kind of what their concerns are, ideas that they came in to the appointment with. A lot of people have had experience with a family member who have had an ostomy and they had bad experiences and the patient's sort of traumatized by that and they need to talk through their previous experiences with an ostomy. And it's actually, those kind of appointments are some of my favorites because in showing the patient the newer ostomy appliances and the different accessories that we have and the clothing that we have designed for people with an ostomy, it really, you can see just their whole demeanor kind of calm down and they realize that this, oh, this isn't as difficult as it used to be, or this has come a long way since, you know, the 70s when they were working with their mom who had an ostomy or something. The new supplies come out every year, and we keep samples of them in our office so that people can see them. But when asking a patient what their biggest concerns are, the first thing they usually say is odor. They're concerned that they're going to smell, that people are going to smell them. And so at that point, we talk about how the pouches, they are designed with a special kind of plastic that contains the odor inside. The odor molecules can't escape through the pores of the plastic. And so as long as the bag is closed at the bottom, as long as there's not a leak, the odor is contained inside the pouch. And then again, that gas filter there, it's impregnated with charcoal. So the charcoal deodorizes the gas as it releases it from the bag. And most ostomy brands, they do that kind of charcoal filter these days. And the other concern people talk about a lot is leaking. Is their bag going to leak while they're at dinner with their family? Is it going to fall off while they're at the grocery store? And so again, letting the patient know that is why we have hundreds of different styles of ostomy appliance, because we are going to find the one that fits that patient. And what I like to tell people is that if you are at home scared to leave your house because you don't trust that your bag is going to stay on, or if you're having problems with frequent leakage and you just can't keep your pouch on, then that means my job's not done yet and I haven't found the right pouch for you. And so we continue to work together long after they left the hospital to make sure that we find the right system for them. Another question I get asked a lot is where they're going to get supplies. And so we just let them know that that's our job. They don't need to worry about it. We have an account set up with a medical supply company before the patient's even discharged from the hospital. And it's got all the supplies they need to do routine ostomy care, and it'll be shipped to their house every month, everything that they need. And that's all taken care of. They don't have to think about that. And then if patients have activities or hobbies that they are looking forward to getting back to doing after surgery, and they have any concerns about being able to do those with an ostomy, I like to talk about them and let them know that there's clothing options, bathing suit options, special kinds of belts that make it possible for people to do any activity that they did before surgery. They can do it after surgery, and we just need to figure out the right system for them. And then the patients often are really concerned about being able to get back to work. And so I know that they talk with the surgeons quite a bit about hernia prevention and not lifting things over 5 or 10 pounds for months after surgery. And patients are usually, they don't want to abide by that. I'm sure Dr. Sikidis has talked with many people about how they can't say that they're going to not lift 10 pounds or more, but they want to eventually get back to work. And I've had quite a few patients here over in Portland. We're close to the coast. A lot of crabbing and fishing and things like that. People are carrying these big, heavy crates, or farmers are carrying big bales of hay, and they're concerned about things being pushed against their ostomy or damaging their ostomy. And so in these conversations, we're able to talk to them about their special stoma protectors. We can deal with that. We can also be careful about where we site mark you, because we can place the stoma maybe a little bit lower for you if you're worried about carrying things up high. All of these things, I just like for patients to just let it all out, let me know what their concerns are, and then we can try to address them if possible. Which I guess then kind of does lead to site marking. We want to work with the patient so that they have some ownership over the stoma. They've picked the spot with us that would be the best spot for the ostomy to go. And so with site marking, typically what I would do is I have the patient stand up. I have them kind of pull their pants low and pull their shirt up, and I look at their abdomen, and then I feel for their rectus abdominis muscles. Usually I have them cough or something so that they can tense up their muscles. I can feel the edges of them, and I put some dots within their rectus abdominis muscles. Then I have them sit down and look down, and any dots that they can't see when they're looking down at their abdomen, those immediately get erased. If it's without the patient, out of the patient's line of sight, I feel like it's just really hard for them to learn ostomy care and then to just do ostomy care in general. So those get erased. Then I have the patient relax their posture and kind of curve forward. I want to see the deepest folds and creases, and any spots that fall into a fold and crease, they get erased as well. And then lastly, I have the patient pull their pants back up to where they usually wear their pants, and I look at their belt line, because that's typically, for a lot of patients, the tightest part of their pants is their belt line, especially if they actually are wearing a belt. And their stoma can be a little bit above or below the belt line, but I don't want it to be directly underneath it. That's a little too much pressure on the stoma and the bag, and that can lead to leaks. If the stool can't find a way to come out into the bag, it sometimes tries to find a way to get underneath the wafer. So we try to avoid the belt line if possible. So any marks that are still left over after all of that, that will get, the patient can then look, and if they have any preference of a higher or lower mark, we try to accommodate that, but typically we try to do lower marks if possible, just because a lot of people are able to put their underwear or their pants up over their stoma and up over their ostomy bag. But any mark that we find appropriate, we then turn into an X, put a clear piece of adhesive on top, and the patient is then in charge of keeping that mark fresh until the day of surgery. We give them an extra marker so that they can go home, and if the clear sticker comes off, they just keep remarking that X until the day of surgery. And then that's pretty much the end of the appointment. At that point, we just remind the patient that the next time that we see them is going to be the day after surgery in the hospital, and we're going to start teaching them ostomy care. So let's actually jump ahead to after surgery. So we will see the patient in their hospital room post-op day 1. If the anesthesia is cleared, if their pain's under control and they're feeling up to it, we start doing education right then that morning. We deliver educational materials. We have a folder that we've created, and inside is just more information about their specific kind of ostomy. We have some extra ostomy scissors. We have paperwork that helps them find support groups in the area. We have troubleshooting techniques. We have a copy of their the supplies that we're going to order for them for discharge, so that they know what to expect at home. Just a lot of resources, but the most important part that's in that folder is our business card with our phone number on it, and our phone number is on basically every piece of paper in there, but they have multiple ways to find our number so that they can get a hold of us after they've been discharged. So without going into too much detail, I wanted to show you just a very basic first teach. So the first time that we're working with the patient, typically we will do the first change ourselves and talk through all the steps and show them what we're doing. The patient just kind of sits and watches, and the family members watch along as well. But we show them how to open and close the pouch and empty it. So empty it, we're letting them know that at home they probably will be sitting on the toilet or standing over the toilet to empty their pouch. Clean the tail of the pouch with a little bit of toilet paper before closing it back up and sealing it. And then we go through how to change the pouch. So using a special kind of adhesive remover that softens up the adhesive so it comes off the skin more gently. Cleaning the skin with just some warm water, drying it really nicely, and then measuring the stoma. We have stoma measuring guides that the patient holds up to their stoma to figure out what size works the best. And then they cut the back of the ostomy wafer. They cut it to the shape and size that they've determined the ostomy is. And then they can attach the bag to the wafer. This is like a Tupperware closure. There's adhesive closures as well. But they attach that and then peel the backing off and stick this onto the skin. The back of the ostomy wafer, this material is heat activated. When it gets so warm on the patient's skin, it starts to gently kind of almost melt the material, and it melts onto the skin. That's what holds it on for 3 to 4 days until the patient has to change it again. So we do all of that, show the patient all of that, and then we set up a time to do it again the next day. And so we typically try to see the patient at least 3 times while they're in the hospital, 3 consecutive days. We'll do it more if the patient is in the hospital longer and they want to, But on the second teach, we have the patient do the emptying and practicing opening and closing the pouch. And then we have them be as hands-on as they're willing to be for the second teach. So usually that's adhesive remover, it's cleaning the skin. Oftentimes, this is where the patient's really looking at the stoma for the first time and touching it and kind of getting to know their stoma. And then by the third teach, we call that our return demonstration. The patient and the family member together often will show us that they can change the pouch, sometimes with a little bit of assistance. But while we're doing all of these teaches, we're figuring out if the pouch that we have put on, if that's the right pouch for them. Sometimes we need to adjust the pouching system. We need to add some kind of accessory. But as we're changing it, we're figuring out the right fit for the patient. And then as soon as we feel kind of comfortable that we've picked the right thing, we will order it from a medical supply company and get that order, the ball rolling, so that by the time the patient's discharged, the supplies are usually about to be shipped to the patient, and they'll show up in about 3 to 5 business days. So right before a patient leaves the hospital, we make sure that they have at least 4 pouch changes worth of supplies so that they have plenty for home while they're waiting for their home supply to show up. And then once the patient's home, we make sure that they know, again, that we are their ostomy nurse for the life of the ostomy. At any point, if they have questions about pouching or supplies, that they can call us, or they can send us messages and photos through the MyChart system that we have. For the most part, we try to troubleshoot over the phone or via MyChart messaging. We try to save patients a trip from coming in. We can usually answer most questions over the phone. But if a patient, we feel like they need to be seen, we can see them in our little closet office. We have an exam chair. And we change their pouch with them. We can try new supplies with them, figuring out what works better, and then give them plenty of samples to go home. This picture on the bottom, my bottom right, is one of our drawers, and it's just full of all the different kinds of accessories and things that we can use to modify a patient's pouching system as needed. And then another service that we provide is that when patients are running low on supplies because they've had leaks or because they just couldn't get their supplies shipped to them in enough time, they call us and we send them supplies from our office or from the hospital to make sure that the patient doesn't run out. So common post-op problems. Here's a couple of the things that we see the most frequently after surgery. So leakage and skin irritation. Oftentimes this is happening because the stoma actually has shrunk maybe a little bit more than we even predicted and has become flat or retracted, or is laying in a bit of a crater or a crease. And the stool has been able to sit onto the skin and has irritated the skin. So for these patients, we teach them the crusting procedure. And I imagine a lot of you know maybe what this procedure is. And if you ever have questions, you're welcome to reach out to me. I'm happy to demonstrate. But it's using ostomy powder to dry up the red, raw, irritated, moist skin, and then sealing the powder into place with like a skin barrier film. And those two together, when they are applied, they develop this dry, textured surface. Essentially, you've created a scab over any open, irritated skin. And now there's that dry surface for your pouch to stick to, and the skin underneath that scab, that crust, gets a chance to heal. So we show patients that. We also get them into a different pouching system that won't leak. We try to, at least. Some patients come in with an allergy or some kind of skin sensitivity. And so these patients, when seen by a dermatologist, the dermatologist often recommends a topical steroid cream or a steroid ointment, not knowing that you can't put ointments on skin that you want an ostomy pouch to stick to. So we have to figure out a way to treat the allergy, to treat that skin and the inflammation while still allowing the patient to pouch normally. So a trick that we learned at Emory is using a nasal allergy spray. Triamcinolone comes in a spray form for allergies. And so we can use that spray and spray it onto the skin, kind of rub it into place, dab off any excess moisture, and then the patient can pouch on top of that. And it really seems to help pretty quickly with redness and itchiness. And so we can show patients that. Patients that are having really high output, their pouches, the usual pouch that we showed them how to use in the hospital, is just getting full so quickly that oftentimes they're having these blowouts at night because they can't empty their pouch in time. So we have high output pouches for patients that are having over a liter a day of stool, and they have a little spout at the bottom that can be attached to a bedside drainage bag. And now that patient can sleep through the night. That liquid stool goes into the tubing and into a bedside drainage bag. And so we can provide the patient with that. But of course, also talking with them about dietary modifications they can make to help maybe thicken the stool, and then make sure that they've talked with their doctor about the anti-motility agents that they can add. We don't often deal with the ileostomy blockages in our office because we don't have a lot of the supplies needed, but in the hospital, we can see patients who are having an ileostomy blockage, and we can do ileostomy lavage, taking a catheter, putting it into the stoma, and then flushing it with like lukewarm water and trying to break up any blockage. We have taught a few patients that in the past who have had really frequent blockages, so they can do that for themselves at home. But it's very rare that we are doing that. Peristomal hernias, obviously we're not the people to fix those, but we can help a patient who's having pouching difficulties because when the hernia is present, it sometimes can kind of push the ostomy appliance up off of the skin, and people can get leakage. So we have special kinds of pouches that actually form to the size and the shape of the hernia and kind of hold on a little bit better and get a better seal. We can also get the patient measured for a hernia support belt. And so we do the measuring, and these are custom made by a company in California. And the patient applies the belt when they're laying flat and their hernia is reduced. The belt goes on, it's put on pretty snugly so that when they sit up, the peristomal hernia cannot really come out very much. It actually kind of keeps the area pretty flat, and the pouching system can stay in place. For patients that are dealing with a prolapse, again, we can't really fix that, but these hernia belts have an option. You can kind of see it maybe in that the belt, the pictures of all 4 belts. At the very bottom, there's one that has what's called an auxiliary strap that goes over the stoma. It's like a little stretchy piece of elastic that goes over the stoma and kind of encourages the stoma to not prolapse out. Gives just a little bit of support to help prevent the stoma from prolapsing. So that's an option for one of those belts. Something we see relatively often is hypergranulation tissue. This usually doesn't cause much of a problem. We don't have to do much with it, but for some patients, it's very painful. For some patients, it bleeds really easily, and that bloody drainage undermines their ostomy seal, and they have issues with pouches leaking. And so in the office, we can treat that with silver nitrate. And again, for some patients, we are able to teach them how to silver nitrate their hypergranulation tissue, and they're able to get a prescription to do that with every pouch change and basically burn the granulation tissue. And over time, it flattens it out and it dries out and is gone. Peristomal ulcers, we actually see quite a few of these, whether it's because the skin has gotten so irritated by all of the drainage, like leakage onto the skin, or if it's from like a cutaneous Crohn's situation, or maybe an abscess that's opened up. These wounds, again, they're so moist, they have so much drainage, it undermines the ostomy seal, and now there's stool that's leaking sometimes into that wound. So we have to figure out how to treat that wound while still giving a good pouching surface. And so we have a few different products that we use for that, but the big thing is that we use a very absorbent dressing. In that picture, it's the one on the right. That one's called Exufiber, but we also have one that's called Aquacel AG. These are hydrofiber dressings, so they're 20 times more absorbent than gauze. This one is impregnated with silver. The one in the picture on the screen is not. But these are put into the wound, and then a second skin, Duoderm, is placed on top. So we're basically creating a Band-Aid over the ulcer. And now we have a surface that the pouch can stick to, and then the wound underneath is being treated. And so patients often can do that for themselves, no problem. And then dexterity issues, whether it's because of arthritis or people are experiencing some kind of neuropathy from their chemo. Some patients have a hard time with the opening and closing of these pouches, which I understand they're sometimes really hard to open. So we have other brands that have a Velcro tab that is easier for people to grab onto. People with dexterity issues can grab onto this tab and the Velcro, and that opens a bit easier. Or there's pouches that don't open from the bottom at all, closed pouches, and the patient just takes the whole pouch off when it's full, and they put a new pouch on the whole thing, and they don't have to worry about opening and closing the bottom. So we can kind of help patients adapt to with dexterity issues. And then this isn't a post-op problem, but irrigation is something that we teach patients, colostomy patients, from time to time. And for those that aren't familiar with irrigation, it's essentially teaching your patient to give their stoma an enema once daily at the same time. And that fluid, it's just, well, again, lukewarm water. The fluid going into the intestine expands the intestine. That signals the intestine to let all of the stool that's in there out. And these patients, they'll have one large, massive bowel movement, and they won't have another one for 24 hours until they do their next irrigation the next morning. And so these patients don't have to wear ostomy pouches. They just wear what's called a stoma cap. It's essentially like a little absorbent sticker over their stoma. And so this process is something that we don't have the facilities here in our office to do the first irrigation with them, but we can demonstrate and show them kind of the supplies and provide them with their supplies and talk them through it. And patients that are able to do irrigation tend to be really, really satisfied with the results. They're really happy about it. And then the last thing I wanted to say, let me just stop sharing my screen for a second. The last thing I just wanted to say was that we let the patients know, I've said this multiple times already, but that we are their ostomy nurses for the life of the ostomy. And we have patients that check in with us every few months or maybe twice a year or something like that to let us know how they're doing, to get us updated on their lives. I wish I could turn the camera around and show you all the like cards and pictures that we've gotten sent from patients, but we develop really good relationships with these patients, and we're able to talk them through the different stages that they experience through their cancer process. So when people start chemo and they're having more liquid output, we're able to transition them to a different kind of bag, or they are getting more skin sensitivity as a side effect of chemo, and how we talk with them about how to treat that. Patients that are going to go in for a scope and they have to do all the bowel prep, the amount of output those patients have through their stoma is sometimes very unmanageable. So we're able to get them into a high output pouch just while they're doing their bowel prep. But of course, we also have patients' families contact us to let us know if the patient has passed, and they want to just let us know kind of how the patient, how they were, kind of talk through the experience. But these patients, the patient's family members call us and ask us if they can donate the patient's unused supplies to our office so that we can provide. I'm going to cry, my goodness. But they want to donate those supplies to us so that other people maybe who don't have insurance have the ability to have supplies. And so it's just a really amazing experience to be a part of these people's lives, and to see people that came into our office during that pre-op appointment just overwhelmed, so scared, and then to see them progress to looking at their stoma, touching the stoma, accepting their stoma, managing it independently, and then letting us know that they just did their first triathlon, or they just went on a trip and they were so happy that they were able to get out and live life again. And so we are very grateful that we're able to be a part of that process and help them through their journey and help them start realizing that they can live such a fulfilling life with an ostomy. And sometimes they just need a little extra support, and we're happy to be that support. And that is my presentation. Are there any questions or anything that you are interested in knowing if they are being discussed with our ostomy patients?
Thank you, Sarah. If I were the patient, this lecture is super clear to me. Thank you. I have quite a number of the oncology nurse here, so I'd like to start with Vattanosot first. Kun Parani, any question from you to ask or consult Sarah?
Yes, thank you, Dr. Wanapa. Hi, good morning, Sarah and your team. I'm very highly regard of your job because at Bangkok Cancer Hospital, I have only 3 of the EG nurse, 1 at the outpatient and 2 inpatients. And difficult to find a nurse inside this job because every day you have to do and care with the colostomy. It's difficult to find the nurse that uh, like to this job. I really appreciate to you. And one question from me about the metric of the quality that you measure of the nursing care when you get a patient with the colostomy or something like that. Could you please share me about the metric of the quality that you measure or follow up with the patient with the colostomy?
Are you talking about like the
KPI,
The
KPI,
KPI like that.
the key performance indicator to monitor that the colostomy care is doing well, no complication,
kind of what the
patient satisfaction, as an example.
Okay, yeah. The slide that I was talking about with it discussed our goals, and it was measuring quality of life with patients with an ostomy. Different companies have sent those surveys out, and I've got to see a few of the survey questionnaires. And my understanding is that the way that we assess how the patient is doing is through the teaching in the hospital and making sure that they're able to perform the task, they're feeling comfortable enough to try that. But then our department, we don't set up outpatient follow-up appointments automatically when a patient leaves the hospital. We have the patient reach out to us if they have questions or concerns, but oftentimes it's them not contacting us is how we know that they are learning and they're feeling comfortable, because we know that we've developed enough of a relationship in the hospital that they will reach out if they have any kind of questions or concerns. So we sort of depend on them to let us know if they have any needs. I don't know if that answered your question exactly, but it's the talking with them in the hospital that we kind of can assess how they're doing.
Can you, if possible, I think I saw in the chat, Dr. Liana, kindly request you to help send us the link of this ostomy care to us. Perhaps on the same time, you can send us the quality of life survey that you briefly mentioned as well, so that the team here can perhaps get the idea of how they capture the ostomy care here.
Absolutely. I can send you links to the articles that I read and that I quoted in the presentation that just talk about the patient experience after surgery and what they attributed to them developing confidence and feeling like they can live life again. Absolutely. I would happily send those links and the link to the kit. We have a distributor, one of the ostomy supply manufacturers, their product rep is the one who gives us our kits when we need them, and they custom make them with the supplies that we ask them for. And so I know that they would love to have everybody use their supplies and would happily get those kits to people. So I will send the link to that too.
Thank you.
Thank you.
We have Yupa from Samitiwe Sukhumvit. Kun Yupa, welcome back. Hello, any question from you?
Not the question now that I said in the Samitiwe hospital is like Kun Watanoson hospital is difficult to find out for the special nurse for the ostomy nurse now. Okay, I think this is a good topic for today. I will apply to my hospital to set up for the ostomy nurse.
Yeah, I think today talk really show, demonstrate very systematic, very organized, and I'm not sure whether or not we have the regular reaching channel for the patient to direct to our ostomy nurse or not. Both วัฒโนสด and สมิติเวชเรามีไหมคะติดต่อตรงเวลามีปัญหา ostomy
มีค่ะอาจารย์ค่ะ
Okay, yeah. They just answer my question that they have direct channel contact from patient to the ostomy nurse as well. Yeah. Next, Pattaya, any question from you? If not, then move to Bangkok Hospital, Korat, please. Korat ค่ะ Korat, I see you on the screen, but I don't hear you.
ไม่มีค่ะ ขอบพระคุณมากเลยค่ะ เป็นความรู้ใหม่ๆค่ะ
Okay, Korat doesn't have patient. Then Phuket ค่ะ Sorry, I skip Payathai too. Payathai too. Okay. If not, then can we move to Phuket ค่ะ
ใช่ใช่
คือขอโทษนะ I'm on the screen I only see a lot of number is that from Payathai too
ค่ะอาจารย์ขอโทษค่ะ พอดีน้องอยากทราบว่าเขาต่อวันคนไข้เขาเยอะไหม
Okay, there's a question of how many patients per day that you have to dealing with you and the team, Sarah, over there.
So it definitely there's highs and lows throughout the year, but on average, I believe we each have roughly 3 to 4 new ostomy patients a week, and that's including the urology patients. We deal with the urostomies as well, but I would say between 8 and 10 new ostomy patients a week, and that's including not just the planned ones, the ones that we knew about for cancer surgeries, but also the emergency ones because of traumatic incidents or whatnot. We have those as well. Yeah, I'd say 10 or so.
Thank you ค่ะ อันนี้คุณยุบเมื่อกี้คุณรัตดาป่ะคะเสียงของ2624-129เนี่ย Hello. Okay. I have a quick question. For ostomy care, do you provide home service or it's a must that everyone have to come to see you at the hospital?
We do not provide home service. Unfortunately, we get asked that a lot by our patients if we can come to their house and do it for them. But no, we are not staffed to see people outside of the hospital. But in the community, there are home health nurses that have some basic ostomy training, and they will provide service to the patient at home. Here, we can just see patients in the hospital or in our office when they've scheduled an appointment.
Thank you. Okay. Any other nurse that I forgot to mention have no chance to ask? Please jump to ask now. If not,
we have an ET nurse, a team of ET nurses in Bangkok Hospital Phuket as well. Do they have any questions? PO
ถามภาษาไทยก็ได้ค่ะถ้าเขิน
ใช่
To say we're so used in this venue, like of communicating, it's very hard if you don't do it all the time. So Art, I think for us, because we see each other so much virtually, it's kind of hard sometimes to ask your questions. They may come later, and I think it will be more than fine to put them in an email form, and Sarah will be more than happy to respond to you because it can be, difficult and intimidating at times. But I wanted to bring 2 points up because there were 2 great questions. What are your KPIs? So it's us surgeons actually that we will kind of judge quality of life afterwards of our stomates. And there are a couple of very well validated tools, survey tools like the SFLQ36 and a lot of other tools that we can use to see where their quality of life is. We have not looked at our patient population. Actually, you're giving me an idea of looking back 10 years of our stomates and see how well our institution is doing. It will be a great quality indicator, but there are those tools nationally. You can find them. Actually, you can Google them and see the survey. But Sarah kind of touched upon the reality is how well a stomate does is how often they communicate with us through EPIC, which is our EHR, our electronic medical records. We have this, kind of HIPAA email, and they go back and forth at questions. And if Sarah does not receive them directly, Brita, who's my nurse here on the call, she can tell you what she receives. And when it's truly when you don't hear and they have usually no issues. And our follow-ups for our cancer patients are pretty frequent. As you very well know, it's every 4 months for the first 2 years, then every 6 months from year 3 to 5. So I know where they are. And like most of them, particularly the ones that have a colostomy, if they have learned how to irrigate, life to them is back to normal. So that is something to think about. And the second question, which is a very good question about home health, as you well know, like in the US, we have a huge shortage of nurses. So it's for us is a luxury. You saw how outstanding Sarah's talk was and how lucky and fortunate we are at OHSU to have her team here. But it's hard. And the home health facility or the home health venues do have some understanding of taking care of a stoma, but not to the degree of an educated wound ostomy nurse. So a lot of times they will come to us with questions, although they do have a home health nurse, and we'll do an outpatient appointment with Sarah's team. So this may not be a new patient, but an old patient is something else happened. They gained weight, they lost weight, the appliance they were fitted, while they were in the hospital does not work for them. The home health cannot address it, and they will see Sarah's team. So I hope that answers also your 2 questions.
I think what you said kind of inspired the idea, because both Samitivet and both Vatanosot are saying the same thing, that it's very hard for them to find a nurse who is willing and committed to do this ostomy thing. So perhaps considering partnering with some home health, which is also available in Thailand as well, could perhaps expand the possibility of having this service, even though in the shortage of finding the nurse here, but with some appropriate training, of course. How serious of the training for this, Sarah, before you get certification in the US, may we know for idea how many hours or how many years?
So each of us took about a year to complete. That was for wound, ostomy, and continence, all 3 categories. I think you can just focus on ostomy and it would only be about 3 or 4 months. And then also keeping in mind that we were all working full time at the hospital when we were doing it. So it probably took a little bit longer. But something I wanted to bring up is that in the past, when we had kind of more adequate staffing, we were asked by a few of the local home health agencies to do a presentation similar to this that just goes over how to change an ostomy appliance or how to troubleshoot an ostomy. And we were teaching the home health nurses some basic ostomy care. We talked to our patients about this, and we let them know that by the time they've left the hospital, they have more training specifically on ostomy care than most bedside nurses. And that's just because there's so much other things that the nurses are focused on that you have to basically go to school to learn ostomy care specifically in order to know what all the supplies are that are available or things like that. So we tell our patients that they might have to do some of the teaching for us and teach the home health agencies and other nurses how to care for their stoma. But I think it's a great opportunity for us to talk with the home health agencies and kind of let them know what we're teaching patients so that they can reinforce that education when they see the patients at home.
Thank you. Any other question for Sarah? 2 more minutes, please.
Professor Art?
Right. Yes, thank you. Thanks a lot, Sarah, for such a wonderful talk, and I'm sure you have such a wonderful team as well, and the support from a very supportive surgeon. The only question that I would ask is that I'm not sure if we have set up a patient supporting team. I mean, like patients who already live life with the stoma could contribute to at least like convince or build up some confidence, talk directly to the patients who's going to be having a stoma, and then helping them with some, like lifestyle issues. Thank you.
Yeah, we have some patients actually that they frequently volunteer, and they say, if anybody ever needs to talk to somebody with a stoma, please give them our name, our number. And that's really wonderful. In the post-op kits that we give people, it has a couple of flyers for local ostomy support groups where they can talk with other people that have an ostomy. And so that is a really great resource, I think, for people after surgery. But before surgery, we actually have one of the physicians over in our pediatric hospital. He has told us that if anytime, especially if it's a child that needs an ostomy, but any adult either that wants to talk to someone with an ostomy, he is happy to go see them in their hospital room and discuss his experience with having an ostomy, and kind of talk them through that while they're here in the hospital trying to make that decision. But I completely agree. It's one thing to hear it from me and from, my experience, but for somebody that actually has an ostomy and their experience talking through it, I think is so much more valuable. So I think we should probably create some kind of database that is a resource for our patients that are considering an ostomy or are overwhelmed with the whole concept. I think that's a great idea.
Thank you. Ajahn Thirawood, any last word from you before we finish? Ajahn Thirawood ka.
Okay, I just would like to thank all of you for your very valuable time to give us very useful lecture. Especially, Sarah, you give us a very informative and practical point of the taking care of ostomy. And I also would like to thank Professor Liana for your very kind support and organize this meeting. We are looking forward to seeing you in Bangkok or in Thailand in December.
Yeah.
Professor
I'm
Liana.
looking forward for it so very
Yeah.
much. I'm so very much looking forward to it, as well as is Brita. She can. So we are
very
gonna.
good.
Yes. Thank you. Thank you. And
Thank
Sarah,
you.
thank you. Thank you for an
Sarah,
excellent.
great job, Sarah. Thank you for an excellent presentation. I want to come see you. If I ever get a stoma, I'm coming to see you.
Please do.
Thanks so much.
Take care. Take
Thank
care.
you very much.
Bye-bye.
Thank you, everybody. Bye, Thailand. Bye, Liana. Wake up.
Bye. Bye, Justin.
Thank you, Sarah.
Thank you.